Okay, hi everyone. It's Dr. Towfigh. Welcome to Hernia Talk Live. My name is Dr. Shirin Towfigh. I'm your hernia surgery specialist. And boy, do we have a treat. We have our first ever hernia couple, Dr. Natàlia Pascotini and Dr. Paulo Barros are both hernia surgeons from Brazil. You can follow them and their journey through the hernia world on Instagram at hernia couple. Very cute. And I just want to say thank you and welcome to Hernia Talk Live.
Thank you so much, Dr. Towfigh. We are
I'm-
really honored to be here with you today.
Thank you.
It's a
Thank
great
you.
opportunity for us.
So I think I met Natàlia first, right?
Right.
Yes, when I was in Brazil.
Yeah, I think it was the first time that we met.
First time. So, as many of you know, we have an international hernia collaboration, and one year we had our meeting in Rio de Janeiro, and that was the first time that I met Natàlia and many, many other Brazilian surgeons. But I specifically remember Natàlia because she was young, she was female. We had a very nice female group. She's beautiful, and she has this amazing story that I learned. From her, I think when we were out to dinner, right?
Yeah, we got out to dinner. Yeah, on a female dinner.
We had a
Like
women in surgery
surgeons.
dinner.
Yeah.
Yeah, to kind of promote more activity and involvement in the society by female surgeons because, as many of you know, the hernia surgery in general is a very male-dominated specialty, and as the decades go by, we have more and more women that are involved in it, which is great.
Yeah.
And now I see you're a hernia couple. So I would love to learn more. I would like to spend this next hour. We have a great audience of patients, very intelligent patients that ask a lot of really great questions. So I will feed those to you. But in the meantime, I'm just very curious to know more about your life, your practice, your specialty, medical care in Brazil. Um, so what city are you in currently?
Now, I and Natalia work in São Paulo.
Sao Paulo. And
I
I'm in Los Angeles. The city has a little over 3 million people. It's a huge city. It's considered a big city. But
Yeah.
Sao Paulo, which is the capital of Brazil, has how many people?
at São Paulo, there are in this moment 20 million peoples, and
20
around the São
million.
Paulo, 25, 26 million
Million
peoples in other cities is very, very close to São Paulo.
Yeah.
Oh my God. That is amazing.
It's huge.
What a huge, I can't wait to come visit Sao Paulo.
Yeah, it's huge.
So California, which is considered the largest state in the nation, is 39 million people. The entire state. And you have 25 million in just one, I guess the county around Sao Paulo. That's amazing.
Yeah.
So Paulo, you have a very different journey from medicine into hernia surgery than Natàlia. And I'd love for you, I think yours is more traditional, like typical. Is that correct? At least from
Yes.
from American standpoint.
My medical school is São Paulo. I finished my medical school in 2009.
Yes.
I finished my residence program in São Paulo in 2015. And the end for my practice, my residence period, I start to study because I work together. I work together with Sergio Hall along the 5-6 years.
Yeah, Sergio Roll, I have not yet had as my guest. He's been very busy, but he's definitely on my list as one of the top surgeons in hernia in Brazil.
Yes, I start I study a hernia. I met you in 2019 in the Las
2019.
Vegas. because
Oh yeah.
my first
I
presentation
was sober. I
yes,
swear I was sober, but I can't say the same about my other friends.
is I don't know, is about the case about the residents.
Yes.
You stay in the audience. I remember when I go out the podium.
Yes.
I see her and you look me and it's a great presentation, very
Yes.
nervous in the moment.
Yeah.
Yes.
In 2021, in the Brazilian Hernia Congress, I met Natàlia. Is a first congress. And
Yeah.
what do you talk about this congress?
So yeah, I had a little different graduation and stuff. So I am from the south of Brazil. So I am from a very tiny, tiny town in the south of Brazil. It's not like Los Angeles or São Paulo. The
Yeah.
city has 86,000 people. Like it's
Wow.
yeah. So I did my graduation in medicine school and residency in cities nearby there.
Mhm.
And then I moved to my hometown again and started my practice as a surgeon.
And
So
your father also a physician, so that's
y-
unique. But was he
yeah,
a surgeon?
yeah, I think this is the main it's like I moved to my hometown. I think one of
Mm-hmm.
the reasons it was like my dad
Yeah.
is a very skilled surgeon. He's retired right now, but at the time, like I lived there after my residency for 6 years. So I started my practice there. And
Yes.
my father has an important role in like guide me at the first complex cases because I
Oh,
was the very first male surgeon in my hometown.
you were the first female surgeon in your hometown. Wow.
And
Your
it's
dad
a
must have been so proud.
yeah, and it's a traditional town. I say that it's a gaucho town. I don't know if you heard about, but gaucho is like the culture from the my state, Rio Grande do Sul. And we have this, it's like we can relate it to cowboys in
Cowboys,
the state.
yes. Yes.
Yeah. So it's people that work in the countryside.
Yes.
So it's very tradition. So it was like a little bit of shocking. Okay, have a female surgeon at first, but I, you know, I nailed it. Thank thank God. And yeah, and it was a pleasure to work there alongside my dad because he was and he is an inspiration to me.
That is so lovely. You know, Luciana was a guest of mine, another great female surgeon in
Yeah.
Brazil, and you have some really great, great friends within the hernia community. So that's very lucky. Now, during your residency, how much hernia surgery did you do, Natalia?
So my residency, it's not like a fellowship of hernia,
Yeah,
residency in general surgery. So I did most hernia surgeries. It was like open surgery.
open, yeah.
And the most part of it was Lichtenstein Repair.
Hmm.
So I did a lot of that. Complex cases, not that much. I think
Yeah,
mm, during all my residency, we did like 10 cases of complex hernia.
10, yeah,
It's
that's very
not
low.
much,
And what
yeah.
about you, Paulo? Did you get a lot of experience with hernias during your residency or no?
Yes, because in 2020, 2012, the Sergio Hall coming to Santa Casa and changed the
Surgical.
view about the hernia.
How
Uh,
one surgeon can change a residency's
yes,
experience is so
because
amazing.
the view is a no complex case, is a normal hernia is not a big problem for general
Yes,
surgeons in Brazil.
yes.
Uh, Sergio introducing the hernia, the idea. I remember is my first time I met the David Chain. and I
Yes.
end my practice because the safe steps about the Lichtenstein.
Mm-hmm.
But the Luciano Tastaldi is a partner me in the residence period.
Yes.
He went in this time. He will go to the Cleveland Clinic for research fellow, and
Mm-hmm.
all the times call me. You need to chant because hernia is very nice. I believe in the moment of residence. Probably I work with the bariatric surgery. I
Yeah.
like the topic, but in 1 or 2 years, I changed my idea and I start to study just hernia.
And now hernia surgery is so popular and bariatric surgery is
Yes,
Yeah.
yeah,
struggling, right?
very
Yeah, I
Good
think it's a
choice.
great moment for us in the
Yes.
field of hernia. Yeah.
Yes.
in,
The
in
story that
Brazil.
I will never forget, Natàlia, is the one that you told me when I saw you in Rio de Janeiro, that you enrolled in the military
Yeah.
on your own
Mm-hmm.
because that was the only way that you could get more experience with laparoscopic surgery. Is that accurate?
Yeah,
Amazing.
that is
Amazing.
true. It's because that my practice in my hometown, it was we have here like a public health system, and in the public health system, we don't have all the resources that we want. So laparoscopic tools, it was not allowed to that patients. So I started to think hernia, it's not just open surgery, it's way more, and I have to study more. So I started to do courses, and I had the idea, maybe the military, it's a good idea to, because they had uh, all the laparoscopic tools, they have resources, they have plenty of patients like to take care of.
Yeah.
So I started like entered in the military to
Yeah.
improve my practice in laparoscopic.
So
So it's
interesting.
amazing. Okay, it was like I have good good feelings about my time there, and I met uh, like a lot of good people there, and this experience made me improve like not personally only, but like a surgeon too.
That is dedication to enroll in the military to advance your surgical skills. That I will never forget that story.
Yeah, I
That is
gained a lot of
dedication.
experience in doing outs or other stuff in the military that I think, you add um you add like proficiency in a lot of stuff, and you become better as a person.
Yeah.
It's
Yeah,
amazing.
very
Yeah.
good. So fast forward, we now have the world's first hernia couple.
Yeah.
So you moved up to Sao Paulo
Yes,
and do you practice together?
Yeah.
Same
I think
office?
yes. It's not so easy for Natalia when you come to São Paulo. She need to start in the zero level.
yeah,
Oh,
you
sure, sure.
start life here.
Yeah.
Because in private practice is the patients come with the clinic.
Yes.
You need to construction your career along the time. uh,
Yes.
Always
True.
is nice, but the
The
beginning is not so
beginning is a
easy.
little tough. Because we don't have differently from United States, we are not okay. We are in private practice here. It's a little
Yes.
bit different from United States, but you are here. Even if you are like we don't have a contract with the hospitals. It's different
Yes.
from United States. So to build your practice, it's tough. Even I moved from a city that nobody knows me, and now I am here in São Paulo. So at the first year, it was a little bit tough, but now things are coming together, and we work a lot of, we do surgeries together. I think
That's
we
so
are we were
fun.
talking days before that we spend like 60% of our time together. Like we share our family, our home, and
Yes.
patients, and during the OR we share experience too.
That
In
is tough.
Brazil is normal. The other physician help the surgeon.
Okay.
It's normal to work together. For example, tomorrow I and Natàlia, I have one surgery, and she helped me. And
Yeah.
Yeah.
Friday, Natàlia have one surgery, and I help Natàlia.
Yeah, we have the same. We have surgeons who assist surgeons. Tomorrow I'm operating on my friend who's a surgeon, will be assisting me, um, which is very fun if you know the person and you like the person. Usually I don't operate with practicing surgeons. I usually operate with residents and fellows. And
Mhm.
so when I do get the chance to operate with someone highly skilled, where I'm not leading them, they're following me really well, I really enjoy that. It's like a gift.
Yeah.
That
We
is
enjoy
so cool.
it too.
So what percentage of your practice is hernia based?
Today I operate just the hernia. I
Oh,
like the chronic pain. In my office, some patients come about the chronic pain.
yeah,
And São Paulo is great because it's a big city. In São Paulo, it's more commonly robot precision. For example, in US, I think is 5,000 robot platforms in this
okay.
moment in US. In
Yes.
Brazil, there are
It is,
150
yeah, less than
robot
100.
platform.
Yeah. We
Sim,
have too much in the United
platforms
States.
that stay in the São Paulo, it's more easy to practice a robot platform
My
here.
hospital has, I think, 12 or 15, just my hospital.
Yes.
Oh, it's a lot.
Too
The
much.
big hospital here is Albert Einstein. In Albert Einstein, there are 5 robot platforms in the Albert Einstein. But
Yeah.
in other hospitals, in private, the big hospitals in São Paulo, there are 1 or 2
Hmm.
robot platforms.
Yeah.
It's
It's
not so
Yeah.
easy.
yeah.
And Natalia, how much of your practice is hernia?
I think maybe I think right now maybe 60 to 70%.
Oh,
It's not
great.
like 100% like Paulo, because he is in the field of hernia a long time, like more time than me.
Yeah.
But I'm trying to be in this field because this is what I want to do for my life. It's like I put all my love, my heart, my dedication, and my time. So I
Yeah.
think hernias, it can impact the quality of life in so many ways, and we
Yeah.
can, fixing that and hearing the patients, examining the patients, and knowing their histories. I think I don't know, it's the most satisfying thing in the surgery field for me.
I mean, I would agree.
Yeah.
Well, that's very interesting because Paulo, you trained under Sergio Roll, who was the first South American president of the American Hernia Society and just world renowned and very, very skilled surgeon. And Natalia, you recently did a fellowship in the United States where you went and had experience with, the greats of hernia surgery in the United States as well. So,
Yeah.
I don't, you should get all the patients with the hernias in your practice.
God listen to
In my
you. Yeah.
opinion, the observership it's very important for us.
Yeah.
It's important because you break your way and you improve your practice. I spent one time in Cleveland Clinic and other time I visit the David Shane, and
Yes.
I told Natalia this opportunity is very important for your life. And
Yes.
in my opinion, the Natalia experience and the observership together, the Vedra changed your life and
Yeah.
your mind.
Vedra's amazing. Yeah, Dr. Augustine was one of my earlier guests on this show, and her episode is one of the most watched episodes because she's
Yeah.
such an
It-
intelligent, bright, wise surgeon. In fact, I just saw a patient of hers. Uh, was it 2 days ago or something, from North Carolina, who she's treating. I mean, so complicated, and she's the best surgeon for that patient for sure.
Yeah, it was an amazing experience to like catching together with and shadowing her. So this was an opportunity that American Hernia Society gave me, like apply to an observership, and I stayed with Conrad Baleser and Dr. Vedra Augustine. So
Yes.
it was amazing. And after
Yes.
that, because of Paulo, because he talked lots about like good things about David Chen, and I met him in these hernia meetings.
Yes.
Then I had opportunity to go to LA and shadowing him a lot of like 10 days. Yeah, it was amazing. And I text you, but we didn't have time to meet. Like,
I know, we were talking back and
yeah,
forth, and I think I was out of town or something had happened, so
yeah,
I couldn't see you while you were here. Would have
yeah,
been
but
great.
maybe in another opportunity.
Why not? Why not?
Yeah.
I need to come visit you guys.
Oh, please come,
Yes.
come. And we are going to make a good barbecue for you here in our
Oh
home.
my God.
This is
Amazing.
our specialty.
Amazing. So the question that I have is, like in my practice, I see about 80% are complications. It could be something simple like a hernia recurrence, or it could be, mesh removal, chronic pain, etc. So is that a problem in Brazil too, where a lot of patients have complications, or no?
Yes.
Yeah.
Yes. And is this
Ye-
mesh related complications, or is it um,
I
like
think
just
in this
surgical
moment,
complications?
in this moment, the complication is the recurrence. The recurrence is because the technique is not
Ah,
the normal recurrence,
Yeah.
the statistic recurrence.
yes,
Is the strategy is not so good for some surgeons.
yes,
Clinical pain, because 18% the patients in the population in Brazil, there it's public health. And in
yes.
public health is very normal to practice Lichtenstein performance.
Lichtenstein. So that's open inguinal hernia repair with onlay mesh. Okay.
And
I mean, the problem with that is if you don't do it correctly, you can injure the nerves, or you can put the
yes,
mesh in too tight or too loose, or usually too tight. Um,
Yeah.
what do you see as the problem technically causing the complications?
yes.
Uh,
I receive some patients
Yes,
because of chronic pain. The most patients is anterior precision, also Lichtenstein precision.
yes,
I need to perform to remove the mesh and practice triple neurectomy, and sometimes I need to fix other mesh.
yeah.
yes,
But it's common in the
Yeah. I
office.
think that we have like in Brazil, we don't have like fellowships in abdominal wall like United States.
yes.
Think we are like shifting to that, but I think it's going to take a long time to achieve this that you in United States have. Because I think every surgeon they like they have to know how to do a proper Lichtenstein repair because this is for us here is the most common procedure.
Okay.
But there are a lot of variations, and not all the surgeons that do a hernia surgery here are specialized, like know all the step by step of the
Yes,
technique. And
yes.
I think that this is the one thing that we get problems with.
So what do you
It's
think is the surgical problem? Do they use a wrong size mesh? Do they put the stitches wrong? Do they not identify the nerves? What is the
it's all that mixed
all of
together.
that? Oh,
Yeah. It's like a small mesh, like the first published article from Liechtenstein. So they pick that one and they stay in that phase. They
Wow.
didn't
Yeah.
like, okay, see, the mesh has to be bigger. And I think that the stitches, it's something that it happens a lot of time. They put like a lot of stitches in the middle part of the fixation of the mesh, and yeah,
Oh.
we have nerve entrapment there.
And laterally, they put stitches laterally.
Yeah,
Yeah.
yeah,
Not
yeah.
enough medial overlap. I was looking that's just the best, the typical mesh size should be around 7.5 by 15 centimeters, right? You have to tailor it a little bit. But I just had a patient with 1 by 4 centimeter mesh. One,
Or
One
1 by 4. It's so small.
why?
I'm thinking
link mesh.
like it's like this big, this much mesh was put in. And I'm
Yeah,
thinking, and of
it was
course the patient
like,
had a recurrence almost immediately. I'm thinking,
okay.
what was going through this surgeon? How do you even find 1 by 4 centimeter mesh? You have to get, you have to
No, you
cut.
have to cut this mesh. You don't find like 1 centimeter mesh. Yeah, I
And just
think
for a child, it would be too small. Oh my God.
surgeons are very creative, you know, and I think that maybe, oh, maybe I can put this and it
Yeah.
could. I think the main problem is that the surgeons don't follow their data. So um, they don't know that this patient recurred or had chronic pain or
Yeah,
this kind of
that's
stuff.
true. Yeah. I have
And
a
I
question for you.
sure a lot.
Um, one of our audience is a Brazilian Jiu-Jitsu purple belt.
Oh, right.
Brazilian Brazilian Jiu-Jitsu purple belts, and they had to stop because they had so many hernia surgeries. So the question is, do you see many Brazilian Jiu-Jitsu related hernias? And after repairing them, do your patients return back to Jiu-Jitsu training?
Sure,
Yes.
sure. I think that these sports, like we can say they sports hernia, but it probably he has like a real hernia.
Regular hernia. Yeah.
Yeah, regular hernia. We can fix and they can like do all the exercise and the martial art. Paulo has experience on that bodybuilder
Hmm.
patients, and he does this kind of procedure, and it's totally okay to, you know, the I think the main purpose of a hernia surgery is that the patient can come back to do whatever they want.
Yes. Thank
Yeah.
you. Yes, I love that. Because how many patients are worried or are told you can't lift anything anymore in your life, you can't travel, you can't. And I'm thinking, no, the whole purpose of the repair is to make sure to bring you back to your quality of life that was made you happy. So we have to make sure we choose the right technique to get you there.
Sure.
So
Yes.
This
Paulo,
was
do you have a specific technique for the bodybuilders? Do you prefer laparoscopic or
The bodybuilding, the problem is umbilical hernia. It's not a
yeah,
big hernia. Uh,
yes,
the problem is
the
the
pressures.
effect of umbilical because he is a bodybuilding is a
Yeah,
competition. I performed a preperitoneal mesh, I input preperitoneal mesh. I
okay.
performed open. I use I cut the skin
inside.
in
Underneath so
the
they can't
umbilical
see it.
region.
Okay.
I close. This bodybuilding is very famous. He stay in how can I say the last competition is more famous is
Oh, it's
Mr. Olympia,
yeah, Mr.
Mr.
Olympia.
Universe. Yeah.
he stay in the 10 top in the this competition.
Wow. Okay, great. So, okay, so you do a small incision inside the belly button so when you stand and you're posing, you don't see it.
Yes.
And then you go through the defect pre-peritoneal, you put a wider mesh than usual. Is that right?
Yes.
And then you just leave the mesh in there and you close the hole.
Yes.
Permanent suture?
permanent suture.
Permanent suture.
But today I think it's better observal suture because
Oh,
he
okay.
don't have a fat in the region. And
Yeah.
one
They can see
month
the knot.
before the surgery,
Yeah.
he
Felt
feel
Feels the knot.
yeah.
yes.
Okay. Yeah, okay. I can see that. He says obrigado.
Oh.
Yeah. We have good people watching.
Yeah.
Okay. What tips? Oh, interesting. So they said when you were observing or shadowing Dr. David Chen, what tips and skills did you observe from your shadowing?
Oh, both of us shadow Dr. David Chen.
Yes.
And for me, I think that one of the best thing, it's not only the mesh repairs, but how he treats patient with chronic pain.
Oh, tell me more. I love it.
Yeah, because these impact in all the spheres of the life of a patient, like
Yeah, yeah,
chronic pain, like it's difficult to live, like the patient doesn't work well,
yes,
doesn't have a relationship well, because he's always in pain. And I think paying attention, like in a truly like knowing that this hurts,
yeah,
and
yeah,
I know what you feel, and I'm going to, I'm going to help you. I think this is the most important thing. And okay, and beyond that, it has the repairs. Like, so I
yes,
saw a lot of neurectomies of these patients that treated with medication and with all this stuff, all the resources that they can have, and
yes,
it doesn't work. So I think now I perform better Lichtenstein and better like neurectomies and
yeah,
better all the practice because of this observership with Dr. David Chen and all the doctors that are all the surgeons that I shadowed.
that's amazing.
Yeah.
Okay, another question. Do any of you, the bodybuilders, this is probably for Paulo, do any of the bodybuilders ever get an inguinal hernia?
Inguinal hernia in my practice, a minimal invasive procedure.
Okay.
Uh, the idea is a big mesh, is a 15 to 10 is the small meshing for us.
Yeah, 10 by 15.
Uh, but the idea to input the mesh, this guy, it's okay to return your practice. In few days, the European Hernia Society talk about the 5 days. I
Yeah,
suggest 1 or 2 weeks because the mesh it's not comfortable for growing region in the beginning, the procedure.
mm-hmm.
I prefer to return in 2 or 3 weeks the normal activity.
Yeah. I have seen bodybuilders with inguinal hernias, but belly button tends to be the more common one. Yeah, not as common in the groin. But yeah, I think laparoscopic surgery is better for the bodybuilders. Also, I would never put an onlay mesh for a bodybuilder because they want to have the definition of
Yes.
their
Yeah.
muscles.
Which is the-
Yes,
Yeah.
yes,
Yeah.
yes, yes.
They don't have fat, like they are going to feel the mesh. And onlay mesh, I think we are not using very often. It's like we use a lot of spaces. Preperitoneal is our, I think, the best region
Yes,
for me, and I think for Paulo too,
yes,
to choose the way the how the layer to put the mesh.
yes,
Only it's not our preference.
I like the Lichtenstein procedure because it's possible to perform for local anesthesia.
yes, that's right.
My strategy is the patients have a problem for anesthesias, a hard problem. I perform only approach, but I prefer a minimal invasive approach for all the other patients.
Yes. So for the Yeah, inguinals, I think you need general anesthesia for the laparoscopic surgery, and definitely you can do just sedation or something
Yeah.
for the Lichtenstein. Now, you're in Brazil, they use a lot of epidural or spinal anesthesia?
It's normal for general surgeries, but
Yeah.
Natàlia don't use.
We don't use.
I just performs for local anesthesia and sedation.
Yeah, we prefer to do like the local anesthesia
Yeah.
or blocks.
Or
So
yeah. And
yeah.
then, so I see. So if the spinal anesthesia doesn't replace general anesthesia, it replaces the sedation with the local anesthesia, right?
Yeah. It's like we perform like with mild sedation, like Liechtenstein, we
Yes.
perform with mild sedation and
Yes.
local anesthesia.
Yeah.
And yeah,
I
and I
agree.
think
Yeah, I
it is
agree with that.
sufficient to like patients get like can walk
Yeah.
and don't have like urinary retention.
Yeah.
So
And
Yeah,
the
I agree. So much better.
yeah, for the
yeah,
pain too.
and the pain 80 hours to the anesthesia reabsorbable, and the patient is possible to go to the house and don't have a
That's
pain.
true.
I need to talk about the patients. The next day
They
you
are going to feel something.
feel something.
Because
Yes,
I
today
know.
you not feel not
Yeah,
not
today you'll be fine. Tomorrow morning,
yes,
I'm
but
sorry.
today it's normal. It's normal. No problem.
Yeah, this is true. This is true. One of your fans wrote a question. Something that was discussed in the last course with the participation of Natàlia and Paulo was physiotherapy to help these patients return to training safely. So when you have athletes, how do you give them advice about physiotherapy and training?
so I think physiotherapy has an important role on like coming back to the normal activities,
Mm-hmm.
especially with these patients that lift like heavier weights,
Yeah.
bodybuilders and stuff. But even for not professional athletes,
Yes.
I think physiotherapy it's important to the core health in
Uh-huh.
general and to learn how to breathe, especially in complex cases like TAR and things that are, more complex than a hernia, inguinal hernia.
Yeah.
So I think that we have a lot of different kind of procedures. So patient with small umbo with diastasis and physiotherapy, it's good for them to, improve the core health before the surgery and after. And we have patient with complex cases that we demand physiotherapy before to prepare
Mm-hmm.
for the
Yeah.
surgery.
Yeah.
The pulmonary
Yeah, improve the
function.
yeah, and
Great.
improve the core health because after the surgery is going to be a little bit different. So patient has to, be used to and have this core health, like healthier core health.
Interesting. Here's a question that was submitted. Hold on. Submitted by one of our guests. One of our other audience members. So it says regarding differences, what are the differences regarding hernia treatment between Brazil and the United States? In other words, now that you've been to both, did you take something from the US and now you're using it in Brazil, or did you actually have fun stuff and innovative stuff you do in Brazil that you brought to our friends in the US and they learned from you?
So I think here Brazil is huge, okay? And we saw both realities. I came from a really tiny town that I didn't have resources and I did mostly open surgeries. But
Yeah.
here in São Paulo, we can compare to United States. We have the same resources, Yeah.
Different is public health. In public health, minimal invasive is completely different. The idea is not normal. It's
Yeah.
open procedure. It's more common. In the private practice, some hospitals in São Paulo and other states, for example, Porto Alegre, Moinhos de Vento, is the same for the practices in the US. There are robot platforms, there are many laparoscopic, and the medical device is the same.
Yeah.
Someone is in Natàlia's hometown. Can they travel to Sao Paulo and get care by you through the public system?
We are now currently in the
Private practice. Okay.
yeah, private practice. So now we are not to be in a public system, you have to be like
Oh,
inside
employed.
a hospital that is
Yeah.
public, and it's a kind of different. I cannot say, okay, I'm going to do this public.
Got it.
Uh,
Got it.
but, you know, I worked for
But
6
someone from the United States can come to see you for your care.
Sure.
Yeah.
You know, Paulo and I receive patients from lots of parts of Brazil and
Yeah.
even from outside Brazil.
Yes. That's
Yeah.
good to know.
Normally, the Brazilian come to
Yeah.
live in other countries and come
Yes.
to São Paulo for procedure.
Because there's a lot of what we call medical tourism where people travel to
Yes.
another country to get a care. So, they go to Turkey to get their hair
Oh,
implants.
yeah, their hair done. Yeah.
Yeah. So, that's really great to know that people can just travel to see you guys, particularly because you're in the in the private sector, and you exclusively do as much as possible hernia-related surgery. And do you work at a hospital or at a surgery, or both?
We work in a hospital and we have like a private office that it's outside
Yeah,
it's
like
not
me. Okay,
yeah. Yeah. So
just
we
like
have
me.
both, like, but we operate only in hospitals. We don't have like a clinic to do that.
Okay. You should open one if you can. It's so much more efficient. And I have my own team. It's the same team every time, so it's so efficient, and the patients get the same exact type of treatment. I really like it.
Yeah.
Okay. Another question. In addition to the choice between open and laparoscopic, what are the main cost drivers in hernia treatment? So do patients have to pay for their mesh separately, or how does it work there?
Minimal invasive more expensive because the devices in Brazil the OR is not very expensive. The price stay in the devices. Minimal invasive, you need more devices. This is more expensive than procedure open.
Yeah. If you use robotic platform, for example, the patient has to pay for the robotic platform here. So health insurance here doesn't cover it. It covers, if the patient has health insurance, it covers the hospital part, but it doesn't cover the hospital and all the devices, but not the robotic platforms
There's
for
an extra cost if you do the
it's an
same
extra
procedure with
cost. Yeah.
Oh,
Yeah.
interesting. So in the
Yeah.
United States, it's not like that.
Yeah. I think that's why you have like thousands and thousands of robotic platforms, because all the patients have access to.
Well, this is what's interesting, is the insurance company will pay you the same. Actually, the insurance company will pay you less for a pay the surgeon less for a laparoscopic or open surgery, or robotic than for open surgery.
Oh, yeah.
Because somewhere someone said, oh, I can do that so much faster laparoscopically, and open takes longer.
Crazy.
So open, actually, they pay more, a little bit, than laparoscopic. And let me double check that actually, because I think they changed it because it was so crazy. Yeah, so if you look at the units, I have it on my desk here, 49650. 6.36 units, 49505. Yeah, it's still the same. It's about 1.5 units more for an open surgery than the same procedure laparoscopic, or so they pay you more. Weird. And
Yeah.
then for so the surgeon gets paid less, and then the hospital usually cannot charge more for laparoscopic or robotic.
Oh, that's
So,
crazy.
Crazy.
so if you're doing laparoscopic surgery, you're probably more profitable for the hospital than robotic because the insurance will pay you the same, usually. They won't pay you more because you're using anything more expensive.
Oh,
So
interesting.
it makes no sense from an economic standpoint for hospitals to get robots, right?
Now,
Economically, it makes no sense.
Yeah, yeah. Here, the who pays is like, you know, the patient has to
now,
pay. It's not
Yeah.
the hospital
but
and stuff.
but in this moment in São Paulo is a great moment because when I use robot platforms, I just use the mesh and the stitch. And why
Yes.
I performs a laparoscopic approach, I need to fix, I need to throw car,
Yes.
and more device.
Yes.
This time the price is the same, laparoscopic and robot procedure, when the patient is a private patients. It's
Yes.
interesting. It's completely different for you talk.
Well, like in my practice, I charge the same because I don't want the patient to think, oh, it's going to be cheaper to do open versus lap. So I don't want them to make that feeling. I need them to just choose whatever is best for them. So for me, I charge the same, whether it's laparoscopic, open, or robotic. If it's the same diagnosis or procedure, I think
Sure.
I think the patient should like make that decision. But the fact that the insurance companies pay less for more advanced surgery is crazy to me.
Yeah, I
But
think
that's
we
why we have insurance companies that are more and more profit every year, and doctors get less and less, and hospitals are shutting down.
yeah,
Okay,
I think worldwide is the same, I think. Yeah, here it's the same. Yeah.
another question. Do you do diagnostic nerve blocks prior to neurectomy when you choose to do the triple neurectomy when you do the patients with chronic pain? And do the patients get dilated, innervated abdominal walls? I don't know what that means.
Me too.
Oh, okay. So this is the question. Number one, when you see a patient with chronic pain, do you first in your office do nerve blocks before you submit to triple neurectomy? Then the second question is, when you do the triple neurectomy, do the patients get like a weakness of their abdominal wall where it gets bulging?
The first for me it's this step the block the nerves. It's very important for understand the pain.
Yeah,
I think this pain is a neuropathic pain. I performed a block. The patients improve the pain before after the block.
yeah,
These patients probably I solved this problem when I performed the neurectomy. I don't told my patients about the time the anesthesia time,
yeah,
because for example 3 days after the use the local anesthesia, the
yes.
patient report no pain. This patient, it's not neuropathic pain, it's all other cause.
Yeah.
And the second is
Oh, okay. If the patient feels like bulge after neurectomy, triple neurectomy.
Triple neurectomy, yeah.
Yeah, I think it's not very common because at first we started doing like triple neurectomy very high, like in the abdomen. And
Yeah.
now we do differently. Like we perform like hybrid procedures in the meantime because patient with pain, chronic pain, most time are related with an open surgery.
Yes.
So we take off this mesh, we do the neurectomy at the how can I say that, at the
Anterior.
anterior,
Yeah.
and then go laparoscopic and do like the the other nerve,
The genital
femoral nerve.
It's more easy to in minimal
Yeah,
invasive
in
cut
minimal
than
invasive. So it's not too high, like
yes.
Got
I saw my idea is the patients develop a chronic pain, is a neuropathic pain. I would like to perform anterior triple
Yeah.
neurectomy.
yeah,
I cut the nerves below the oblique stern muscle, oblique
Yeah.
intern muscle,
yeah,
and the genital femoral. The patients don't solve this pain. I performed the posterior triple neurectomy. I cut the nerves below the quadratus lumbar. When I cut this nerve, the iliohypogastric and ilioinguinal in the quadratus lumbar, these patients develop a bulging
Yeah.
in the region for inguinal
Yeah.
region.
in most patients, we can solve the neuropathic pain performing like the anterior neurectomy
Yeah. Yeah.
with
So, well, what has never been shown in textbooks is that ilioinguinal and iliohypogastric nerves have a motor function, right? That they serve the abdominal wall muscle. It was always groin pain, groin, skin hypersensitivity, and so on. So when we went from anterior triple neurectomy, which is like the common triple neurectomy, higher up to posterior triple neurectomy, we said, oh my God, these people are getting bulging. So what you're doing is exactly right. As much as possible, stay anterior. So cut the nerve as far away from the spine as you can to
Yes.
reduce the risk of denervation, so where the abdominal wall gets affected. And then even if you, so I personally am not a fan of any type of like laparoscopic triple neurectomy. I think that's really when you get the injuries to the abdominal wall. But if you have to, then do it as far away from the spine as possible, because that's you're least likely to get the motor branches, right?
yeah,
Yeah, it's a problem. It's a problem because there's no good treatment for that once that nerve is cut.
yeah,
Um,
yeah,
I'm trying to err more on using, ablation therapy, and it seems to be less damaging to the nerve than actually cutting it if it's possible for the
yeah.
ones that are more proximal, like upstream. Okay, we have more questions. Okay. Are there situations in which, here, let's do this. Are there situations in which hernia-associated pain spontaneously resolves, leaving patients free to consider watchful waiting as an alternative to immediate surgery? In other words, if they go from no pain to pain, will they ever go back to no pain?
Okay.
Sorry.
So, pain with a hernia, right?
Yes.
Patient
Yes.
has a hernia, have pain, and it solves like spontaneously, right?
Yeah. Can the pain ever go away without surgery?
Yeah.
Yeah, I agree.
Yeah, I think it's really possible because
Yeah.
especially in males
Yes.
that we can do this watchful waiting strategy.
Yes.
But
I
it's very
agree.
important. These patients come to the clinic and the physician examine this patient. And
Yeah.
the watchful wait is the idea for the physician, is not
Yeah.
the patient.
Yeah, do a follow-up, like
Small hernias,
Good point. Good point.
yes, this is
Yes.
important because they
Very
all
good point.
small hernias, the patients a few symptoms, it's possible to watchful wait.
Yeah.
I like this idea because the big problem for fix the inguinal region is the chronic pain. Watchful wait, probably the young peoples develop a pain along this watchful wait, this time,
Yeah.
and
Yeah.
need to fix it. But the old patients probably is not necessary to fix it,
Yeah.
the hurt.
yeah.
It's
Yeah.
a great idea.
Yeah,
I
but
agree.
in female, I'm
Doctor.
a little bit worried about incarceration, and I don't feel that watchful waiting it's a good way to to lead the hernia in female.
Yeah,
And
the University of Michigan group is just got, I think, did they get grant funding or they applied for grant funding to do a female watchful waiting trial? Because as you know, all the watchful waiting trials were male only.
yeah,
It's not so easy because just 3% the humans the developer the man's 30%
Yeah,
developing, it's more easy to understand along the time
yeah.
this
But
yeah.
if you analyze
this
Brazil, it's more we have more women than men, like in population in general. So
Oh, interesting.
yeah, so 3% maybe it's something
Good
in
number. It's a good number.
population that
Yeah.
it's almost women.
Yeah,
Yeah.
I think based on my own practice, where I see so many women with undiagnosed inguinal hernias, their pain is, they say it's in your head, and they don't say it's from your hernia. So
Yeah.
they're discounted, not diagnosed. That number is probably a little bit higher, but certainly not as high as men's, as far as we know.
Yeah.
Um, I would say sometimes I see patients that see me because they had a hernia and they went to their medical doctor and they said, "Oh, you have a hernia. Stop the gym, don't do any exercise, etc." And the hernia actually gets
Okay.
worse.
Yeah, this is
They
so
have pain.
unfair to the patient.
Yeah, now they have pain. They've gained weight. And I said, "Listen, go back to the gym, do all your exercise, lose the weight. If you still have pain, I'll fix you. But if the hernia gets smaller, actually, because you have better muscles and you have no pain, you're done."
Yeah. Yeah. And here it's common when patient comes with us, they have our phone numbers. So
Oh, wow. I love
our
it.
personal phone numbers. So if the patient comes to us, they have this no the number and they're okay. We are not sure if you are going to operate. We are going to do a watchful wait.
Yeah,
If at some point you get worse on the pain or you have some problems, call me. And that works because patient feels that they are secure doing that and they have how to reach us. So
yeah, yeah. And here's a question related to that, which is, does a sedentary lifestyle give you higher risk for developing new or recurrent hernias? There's one trial that showed, I think it was in Swedish women, those that exercise regularly had a lower risk of hernia than those that didn't exercise.
I think that the lifestyle in general, it's more important than only the sedentary lives. Like,
Yeah,
diabetics,
yeah,
tobacco, obese patients.
people that don't eat properly and I
yeah,
think hernia it's a multifactorial
yeah,
so it's not just doing exercise. I think
yeah,
it's the way this lifestyle that you have can impact on all your health, like, but hernias too.
yeah. I 100% agree. So this is coming to the end of our wonderful hour. I told you it would go really quickly.
Yeah.
I have so many more questions, but I'm going to have to do it in person next time. Um, for Americans or anyone else who's watching in the audience, because I do have an international audience, if they want to see you for a consultation, how do they find you?
Oh, first, I think they can follow Hernia Couple, and
Yeah,
we are now launching our website.
okay.
It's Hernia Brazil with S. We spell it S here.
Yes,
So we are like putting on this website all the information about not only our clinic, our office, but good data about hernia, like
great,
all the kind of stuff based evidence-based information there. So
great.
even patients or surgeons that want more information about hernia can
Yeah.
reach us. And I think maybe this week, Hernia Brazil is going to be launched, so they can follow us on Hernia Couple, and they can get this website with this good information.
Okay, I love it. And so that is how we're going to end it. Follow Hernia Couple at Hernia Couple on Instagram. Although doctors Pascotini and Barros have their own Instagram and Twitter pages as well. I have my own. Don't forget to follow me on X and on Instagram at HerniaTalk. And for those of you that have been submitting your questions on Facebook, I appreciate you. And know that this episode and all prior episodes are available on my YouTube channel at HerniaTalk. And if you like to watch or listen to podcasts like I do, you can do the same on any podcast at HerniaTalk Live. So thanks again, you guys. I really appreciate it.
Thank you
Thank you
so
so much.
much. We are
Bye.
honored to have you have here with us.
I
Thank
Thank
you.
you. Okay, see you later. Bye-bye.
See you.
See you.
Bye-bye.
Bye-bye.